Hi, I'm Dr. Lillie Davis, a veterinary oncologist, and today I'd like to talk to you about canine mast cell tumors. Let me tell you a little bit about myself. I went to Cornell University for undergraduate and got my Bachelor's of Animal Science in 2009. I went on to complete my degree of veterinary medicine at Cornell University and got my veterinary degree in 2014. I then moved to the Midwest to Indiana to complete my small animal rotating internship at Purdue University. After that, I went back to Cornell University to complete my residency in medical oncology. And thereafter, I'm currently practicing veterinary oncology in the Philadelphia suburbs. So now I'd like to tell you about our topic of today, canine mast cell tumors. Canine mast cell tumors are the most common cutaneous tumor in dogs, and they represent about 21% of all cutaneous tumors in dogs. They vary in their appearance such that they can go from benign to malignant, and that's what creates the most difficulty in treating these tumors, in that they can look like virtually anything. So they can appear in any place on the body, and they can feel and look like any lump or bump. There are two types of mast cell tumors, cutaneous and subcutaneous. Cutaneous mast cell tumors are the more common mast cell tumors that I'll be discussing today. And subcutaneous mast cell tumors are not as common, but are thought to be a bit more benign in their behavior, such that they're less likely to metastasize, and also, when they're incompletely excised, they're less likely to recur. But for the sake of this conversation, I'll mostly be focusing on cutaneous mast cell tumors, as those are the most common type. There are many prognostic factors that give us an idea of the behavior of these mast cell tumors in terms of their aggressiveness. The most important and most consistent prognostic factor is histologic grade. There are two grading schemes. The first well-known grade is the Pacnic grading scheme, which is grades 1, 2, and grade 3. Grade 1 mast cell tumors are your more benign mast cell tumors that are generally well treated and completely cured with complete surgical excision. Your grade 2 mast cell tumors can act like grade 1 or grade 3, and therefore their behavior is extremely variable. Whereas your grade 3 mast cell tumors, or high-grade mast cell tumors, are the tumors that are most concerning, such that they have a high metastatic rate that can range anywhere between 55 and 96%. And we know that even with complete surgical excision of your grade 3 high-grade mast cell tumors, there's a 36% chance of them recurring, which is pretty worrisome. The second grading scheme, the Kupel grading scheme, has two tiers, low and high grade. The low grade corresponds with the Pacnic grade 1, and the high grade corresponds with the Pacnic grade 3. This grading scheme, being the Kupel grading scheme, is a bit easier to understand and a bit more reliable in terms of predicting mast cell tumor behavior, in that the problem with the Pacnic grading scheme is that grade 2 mast cell tumors can behave like 1 or 3. Therefore, with the low-high grading scheme, there's less variability and more ease at being able to determine how biologically these tumors will behave in the future. While grade is the most reliable prognostic factor, there are also other negative prognostic factors to keep in mind that give us an idea of how aggressive these tumors can behave. Several of these negative prognostic factors outside of high grade include tumor location, with mucocutaneous junctions and genital locations being the locations associated with a higher aggressive grade mast cell tumor. Tumor size is another one, meaning that the bigger the tumor and the faster it grows, the more aggressive behaving that tumor is as well. The other thing that also adds to negative prognostic factors is breed. So we know that these brachycephalic breeds, such as pugs and bulldogs, can have the low grade or grade 1 mast cell tumors, where breeds like Shar-Peis can have the higher grade mast cell tumors. Another negative prognostic factor is mitotic index, which is an assessment of the number of mitotic figures seen under the microscope by an anatomic pathologist. And the mitotic index cutoff for mast cell tumors, as far as aggressive behavior goes, is about 3 to 4. So we know that those mast cell tumors that have a mitotic index greater than 4, no matter the location and no matter the grade, those are a bit worrisome in terms of their metastatic potential. The presence of a c-KIT mutation is another negative prognostic factor, and we know that about 20 to 40% of mast cell tumors have this mutation, and those that do are generally more aggressive in behavior. Another negative prognostic factor is tumor recurrence. When these tumors have been completely excised, which most of them generally should be, they can recur, and grade 3 or high-grade mast cell tumors actually have a 36% chance of recurring even with complete excision. So those tumors that have been excised and recur, we know that they're likely going to be high-grade tumors. And lastly, those tumors that metastasize, with metastasis normally going to the local lymph node first and then to other visceral organs such as the spleen or the liver, that's a generally poor prognostic factor as well. So what do you do if you suspect that a dog has a mast cell tumor? Well, the first thing that every veterinarian should do on any dog with any lump or bump is aspirate the mass. Because mast cell tumors, as I've said, can look and feel and be anywhere and feel like anything. Therefore, the first diagnostic step is to do fine needle aspirates. And in-house cytology is usually adequate to tell for mast cell tumors, but also submitting them to a clinical pathologist is helpful too. After you've realized this dog has a mast cell tumor, one of two things can happen. Either we can move on to surgery, which gives us an idea of grade, or we can do diagnostic staging tests to tell us the extent of the disease. And what that can include is basically full blood work, so CBC, chemistry panel, urinalysis. Abdominal ultrasound is pretty important because we know that these tumors can metastasize to the visceral organs, such as the spleen and the liver, and intra-abdominal lymph nodes as well, even though that's less common. The other important diagnostic tool is fine needle aspirates of the lymph node closest to the mast cell tumor. We know that mast cell tumors tend to metastasize first to the regional lymph node, and therefore aspirates are pretty important to give us an idea if there's evidence of metastasis or not. Chest x-rays are important, but not because we expect mast cell tumors to metastasize to the lungs, but usually these dogs can be older and there may be some predisposing factors. Now I'd like to get into the treatment of mast cell tumors, with the first most important treatment being surgery. Surgical excision is not only important as it's the primary treatment modality for mast cell tumors, but it also gives us really important information regarding grade, which, as I've already discussed, is the most important prognostic factor. For surgical excision, there are several things to keep in mind as far as what mast cell tumors should you cut as a primary vet, or what should you refer to a surgical specialist. And the most important factors are large tumors, so tumors that are so big that there is likely or low likelihood of getting complete excision. Those tumors should definitely be referred to a surgical specialist. Or tumors that are hard to reach in difficult locations, such as the distal limb. Those are definitely tumors that should be referred, as the chances of getting complete excision with one surgery are more likely, especially if they're referred to a specialist. The other things to keep in mind regarding surgery is surgical margins. So when you're removing mast cell tumors, you not only want to remove the tumor and debulk it, you want to remove enough of the normal tissue around it such that we're not leaving any tumor cells behind. And we know that this is important because if we leave any mast cell tumor cells behind, the likelihood of recurrence is pretty high. Therefore, there exists surgical margins that should be abided by no matter what location the tumor is in, such that there should be at least 3 centimeter lateral margins and 1 deep fascial plane. Now, these don't guarantee complete excision, but it makes the likelihood of complete excision more of a success. The other thing to keep in mind with surgery as well is the translation of these surgical margins to histologic margins. And when we're looking at a biopsy report, that's where we get an idea of, okay, was our surgical excision successful or not? Adequate surgical margins include lateral margins greater than 3 centimeters and 1 fascial plane deep. Adequate histologic margins, meaning how we can tell a mast cell tumor is completely excised from the biopsy report, is 2 millimeters or greater and 1 fascial plane deep. Anything greater than 2 millimeters is adequate, but this truly does depend on size of the tumor and the grade as well. Another thing to keep in mind when surgically removing these mast cell tumors is ensuring that you submit the tumor in its entirety. This gives us the best chance at getting a most accurate grade, as these tumors are pretty heterogeneous. It's also very important to ensure that if you suspect there is metastasis to the regional lymph node, that lymph node is also surgically excised at the same time that the mast cell tumor is removed. As we know, generally speaking, surgical excision, not just of the primary mass, but also of the metastatic lymph node, can allow for a longer survival time for dogs with metastatic mast cell tumor. The next thing to also keep in mind is that pre-treatment with steroids is generally not recommended. This is because steroids alone have a pretty robust response rate in terms of killing these mast cell tumors and therefore shrinking their size dramatically. Usually what happens is when we're using steroids to pre-treat these mast cell tumors prior to surgery, while the tumor may shrink, there's still cells left in the periphery. So when you're removing that smaller mast cell tumor after pre-treatment with steroids, you're actually leaving these tumor cells behind and setting the patient up for recurrence. If you need to use steroids prior to surgery, it's pretty important to document the tumor. That means shave around the region and outline the tumor with a Sharpie, realizing that the goal, even when you're pre-treating with steroids, is to get adequate margins around the original tumor margins before shrinkage. Keep in mind that likely incomplete margins are going to be obtained. Therefore, we're likely going to have to use secondary treatments such as radiation therapy, plus or minus another surgery. Overall, I generally don't recommend this, but again, sometimes this is the best and only way to remove those big bulky tumors. Most importantly, when in doubt, refer to a surgical specialist. So after surgery, you obtain the biopsy report. Now what? There are several things to look at that give us some clues as to how aggressive these tumors may or may not behave. The first thing that I look at are margins, which we've already discussed. The second thing that I look at is grade. So grades 1, 2, 3, or grades low, high. You will see the two grading schemes that I discussed on the report. For example, you may see grade 2, low grade mast cell tumor. The most important takeaway from that interpretation is it's a low grade mast cell tumor. The next important factor to look at on these biopsy reports is mitotic index. This is an objective view or objective number giving us an idea of how fast these tumors are replicating, such that the anatomic pathologists are counting the number of mitotic figures per 10 high power field. For mast cell tumors in particular, there is a cutoff number such that 3 to 4 is a pretty scary number, and we know that those tumors that have a mitotic index greater than 3 to 4 can have a higher potential to metastasize and therefore are more aggressive. At the bottom of these biopsy reports, you'll see a paragraph discussing the prognostic panel. And for the most part, we do not recommend that the primary veterinarian submits this prognostic panel, as it's rarely useful for these mast cell tumor dog cases. Instead, we highly recommend that you leave it up to the medical oncologist to decide if using this prognostic panel is clinically relevant. What happens if surgery is performed and the margins are dirty? There are several options as far as local tumor control after surgery is performed. The first option is a scar revision surgery. We know that with a second surgery, there's greater than a 95% local control rate if a scar revision surgery is successfully performed. If for some reason a second scar revision surgery is not possible, then the next treatment modality would be radiation therapy. We know that greater than 90% of incompletely excised mast cell tumors are controlled with adjuvant radiation therapy. And lastly, if for some reason scar revision surgery or adjuvant radiation therapy is not an option, then chemotherapy is the next and last option for local control, although this is not the preferred method. 11 to 12% of dogs can present with multiple mast cell tumors, and sometimes there are dogs who I lovingly refer to as mast cell tumor factories that keep popping up with multiple mast cell tumors throughout their entire lifetime. The biggest question that I get from primary vets is, when do we cut these mast cell tumors that keep popping up? And there's truly no right or wrong answer. The first option is to surgically excise each mast cell tumor as they arise. This option is the most straightforward way to address these cases, but can be pretty expensive and can be pretty laborious as far as putting the patient through multiple surgeries, as these tumors can pop up at any time. I've had patients come to me with mast cell tumors that are removed and then several weeks later have to have more removed. The next option is to batch these surgeries together. Anecdotally, I had a client whose pug had multiple mast cell tumors that popped up throughout his entire 11-year life, and he's actually still alive. And what this client did was she looked and targeted each single mast cell tumor as they came about and made a note with a Sharpie, and as a certain number of mast cell tumors popped up, so for example, 3 mast cell tumors, she would then have them removed. So every 3 mast cell tumors, this client would have the mast cell tumor surgically excised. And that's one way to do it too. The other option is to refer to a medical oncologist, as some medical oncologists use chemotherapy as a way to control these cases that keep popping up with mast cell tumors over and over again. There's no evidence-based medicine that shows that chemotherapy can prevent the formation of new mast cell tumors. However, that's something that anecdotally can work. Ultimately, we think that these dogs who come in with multiple mast cell tumors have a predisposition for getting them because of their likely historical allergies. There's some thought that there is some genetic predisposition outside of breed, such as atopy, that just makes these dogs more likely to get multiple mast cell tumors over their life. Therefore, I generally recommend that these dogs develop a relationship with a dermatologist, as allergies can be an underlying factor. There is a new treatment for canine mast cell tumors called tigenolol tigolate. It's a novel diterpene ester that's derived from a rainforest plant. Tigenolol tigolate causes a localized inflammatory response, which then leads to disruption of the tumor vasculature, leading to the induction of tumor cell death within 2 to 7 days. All of this forms a wound, and that wound resolves within about 28 to 84 days after treatment. The overall response rate for this localized treatment is about 80%, with 89% of dogs being tumor-free after 12 months. So far, minimal side effects have been reported for this treatment option. And this is a really good treatment modality when surgical removal of mast cell tumors is just not feasible. The next treatment modality I'd like to discuss is chemotherapy. So for canine mast cell tumors, when is chemotherapy indicated? The first situation in which we use chemotherapy is when the mast cell tumors are not amenable to surgery, such as too large in size, or those difficult locations we talked about, such as the distal limb. The next situation where chemotherapy is indicated is those tumors that have metastasized, either to the local regional lymph node or the visceral organs, such as the liver or the spleen. The next situation where chemotherapy is used is for those high-grade grade 3 mast cell tumors. That's due to the high propensity or the high risk of metastasis. So even in those high-grade tumors that have no evidence of metastasis at diagnosis, we still recommend chemotherapy be used in the adjuvant setting. And the last situation where we use chemotherapy is in those high-risk locations, such as the mucocutaneous junctions. There are various types of chemotherapeutics that we can use for canine mast cell tumors. Of those various chemotherapies include vinblastine, lomustine, and chlorambucil. These therapies can be used in combination or as single agents. All of them have similar response rates between 30 and 65% in the gross disease setting. That means with the bulky tumor not removed surgically. In this setting, remission is possible, but a cure is very unlikely. The hardest part with chemotherapy treatment for mast cell tumors alone is that while the response can be pretty robust, it's not a very durable response. Generally speaking, if a complete or partial remission is obtained, we're looking at a response time of 4 to 6 months before the tumor or the disease starts to progress. What chemotherapy protocol is used is very clinician dependent. For example, for those more aggressive mast cell tumors, I personally tend to use a combination of lomustine, vinblastine, and prednisone. The most commonly used chemotherapeutic is vinblastine, and how this treatment is given is once a week for 4 treatments, and then every other week for an additional 4 treatments. So therefore, it's given 8 times total, unless it's being used in the gross disease setting. In that setting, it's used indefinitely. This treatment is generally combined with prednisone, as we know there may be some synergism between vinblastine and prednisone. When vinblastine is used alone, the response rate's about less than 12%, but when used with steroids or prednisone, it's greater than 47%. Therefore, we tend to use vinblastine with prednisone. However, we taper the course of prednisone over 3 weeks. Oncologists use prednisone with chemotherapeutics in a variable way, such that it's unclear if prednisone is useful in the microscopic disease setting. However, it's not right nor wrong to use prednisone in those dogs who've already had surgery. The next major chemotherapeutic used to treat canine mast cell tumors is lomustine, which is also coupled with steroids or prednisone. Lomustine has an overall response rate of about 42%. This chemotherapy is administered by mouth, as it is a tablet or capsule, and it's given by mouth every 3 weeks. The potential side effects include myelosuppression or bone marrow suppression, liver toxicity, and there's also a cumulative platelet toxicity that also can occur. When used in combination with vinblastine and prednisone together, the overall response rate is about 65%. And this is one of those protocols that I do use for those more aggressive mast cell tumor cases. Another chemotherapeutic not as commonly used for canine mast cell tumors is chlorambucil. This is another pill that's given by mouth either daily to every other day. The overall response rate is about 38%, and the side effects are quite minimal for canine patients, and it's pretty well tolerated. The next treatment is tocitinib phosphate, which is an oral chemotherapeutic that targets the c-KIT mutation. Dogs with mast cell tumors with the c-KIT mutation are twice as likely to respond to this treatment, but overall, the response rate is about 37% for canine mast cell tumors. This drug is given orally either every other day or Monday, Wednesday, Friday, and the most common side effects include GI or gastrointestinal side effects such as diarrhea, less likely vomiting, decreased appetite, so therefore it's generally recommended to give this drug with food. You can also see immunosuppression such as anemia, a low white blood cell count. You can also see rare side effects such as a protein-losing nephropathy. You can also see hypertension or high blood pressure, and less likely lameness. The next treatment modality for canine mast cell tumors is radiation therapy. Radiation therapy is indicated for mast cell tumors that are incompletely excised or those very large non-resectable mast cell tumors. For grade 1 and 2 incompletely excised mast cell tumors, definitive radiation therapy allows for greater than 90% control rate for up to 5 years. And for your grade 3 mast cell tumors, a 65% control rate for a median of 23 months. The second radiation treatment option is palliative radiation therapy. This is a shorter course of radiation therapy with the goal being to enhance patient comfort by decreasing inflammation associated with the mast cell tumor. The risk with this is anaphylactic shock. Therefore, this treatment modality is not commonly recommended. The next group of medications that we use for canine mast cell tumors is supportive medications. These are generally used in the gross disease setting. And the goal of supportive medications is to decrease the side effects that occur from degranulation and histamine release from the mast cells in the mast cell tumors. The first supportive medication that we use is diphenhydramine, which is a histamine 1 receptor antagonist that's used to decrease the inflammation and irritation caused by local histamine from the mast cells in the mast cell tumor. The second supportive medication is famotidine, a histamine 2 receptor antagonist in the GI tract. This medication is given because we know that increased histamine levels can cause increased gastric acid production in the GI tract. In one study, 35 to 83% of dogs with mast cell tumors had gastric ulceration at the time of necropsy. Therefore, giving famotidine is a pretty important process in treating dogs with mast cell tumors, along with giving diphenhydramine. So that's everything you need to know about mast cell tumors. If you like this program, please hit the like button and stay up to date with everything vet med by subscribing to this channel. If you'd like to hear more from me, you can follow me on LinkedIn. Thank you for joining us.